Good afternoon, all. My study is on the comparison of ORTHOPTEK versus occlusion therapy as a treatment modality for amblyopia. So, as we know, amblyopia remains the leading cause of visual impairment in children, and it's a non-organic condition with unilateral or bilateral decrease of visual function caused by form vision deprivation or abnormal binocular interaction. And occlusion therapy remains the gold standard in which patching of the sound eye forces the amblyogenic eye usage, but the limitations include poor compliance, social stigma, skin irritation due to the glue used in the patches, and the psychological impact on the child. Orthoptic therapy is a newly developed non-invasive therapy. It's a top-down approach that stimulates different areas of the brain to develop vision centers, and it is effective for both adults and children. Here, the patient is made to sit at a distance of 1 meter from the monitor, wearing the full refractive correction. In the first part, the patient is asked to locate the peripheral light with the help of a laser pointer, and the second part, the patient is asked to fixate at the central point while counting the lights he or she sees at the periphery. The rationale of the study: there are computerized therapies promote cortical plasticity and binocular recovery, and there is limited Indian data comparing these modalities with occlusion therapy. So there's a need to evaluate whether a binocular therapy tool like ORTHOPTEK is equally effective to occlusion. The aim is to compare the visual outcomes of ORTHOPTEK therapy versus occlusion therapy in children with amblyopia. The objectives are to assess the improvement in best-corrected visual acuity and to evaluate the compliance among both groups. It is a retrospective comparative study of 1 year duration. 42 patients were included, 21 patients belonging to the occlusion and 21 belonging to the orthoptech category. Statistical analysis was included, chi-square test for demographics, repeated measure ANOVA for treatment effects, and SIDAX post-hoc test. A p-value of less than 0.05 was considered significant. Inclusion criteria included children of 5 to 14 years diagnosed with unilateral bilateral amblyopia with corrected and stable refractive error, cooperative and motivated patients, and no previous amblyopia therapy in the past 6 months. Exclusion criteria include those with any history of ocular surgeries in either eye, any neurological disorders affecting vision or cooperation such as cerebral palsy, any uncorrected or unstable refractive error, uncooperative behavior, or poor cognitive ability. Methodology: occlusion therapy include patching of the sound eye 2 to 6 hours per day depending on the severity of amblyopia, and the duration is 6 to 12 months. Compliance monitored through parental diary, random patch checks, and clinical observation. Outcome variable was best-corrected visual acuity. The orthopedic therapy was performed in clinics under supervision, and the frequency of one session every day for 10 days within a span of 10 to 14 days. The duration of each session is 60 minutes, and the count is determined by the severity of the amblyopia, and the outcome variable is best-corrected visual acuity. Coming to discussion, age distribution. The blue color indicates younger children, the red color indicates slightly elder children. In the orthoptech group, there was slightly elder children was included, but statistically, the p-value was more than 0.05. So the age distribution was similar among both the groups. Sex distribution also was similar among both orthoptech and occlusion group, with slight male predominance among both the groups. So coming to change in visual acuity among the occlusion group, before occlusion, the 76.2% were with visual acuity of 6/9 and 23.9 were with less than 6/9 acuity. And after occlusion, around 85.7% achieved a visual acuity of 6/6 or 6/9, with 14.4% remaining with visual acuity of less than 6/9. And before orthoptic, 50% were with visual acuity of 6/9 and 50% were with visual acuity less than 6/9. Implies that numerically there was the orthoptic group starts with a slightly worse baseline acuity, and after orthoptic 82.2% with visual acuity of 6/6 or 6/9, and the remaining percentage were with visual acuity of less than 6/9. Coming to within the group comparison, occlusion therapy, the mean improved from 0.114. So it was significant with a p-value of less than 0.05, that is 0.001, and orthoptech also shows significant p-value that is less than 0.05. So in conclusion, both groups were effective in the effective treatment modalities in treating children with amblyopia, but between the group comparison shows a p-value of more than 0.05. It implies that although occlusion and orthoptech individually are significant, produces significant results, but in comparison, there was no significant difference between the results produced by both the groups. So in conclusion, occlusion and orthoptech produce similar results among children with amblyopia, but the orthoptech carrying forward the advantages of good compliance, no social stigma, no skin irritation due to the glue or knot, no psychological problems, and the main highlight is the short duration. Orthoptech produces the result within a period of 10 days, which is produced by the occlusion of minimum 6 months. Our limitations include CFs was not included, small sample size, short duration, and it was a retrospective study. These are my references. Thank you.
Thank you. Thank you, Devika. So you're saying that with the ORTHOPTEK, you only had to do it for 10 days.
Yes.
Whereas for the occlusion group, they had occlusion for 1 year.
Orthoptech group, we have followed up for 6 months. But
No, how many days of ORTHOPTEK, because they had to come to the clinic, right? You showed that they only had to do ORTHOPTEK for 10 days.
Yes.
So compared to a whole year, this is only for 10 days?
After 10 days, they will be called a follow-up every month.
Okay, and they don't need to go back and repeat either ORTHOPTEK or occlusion at all?
Usually, we just taper the sessions. After a period of 10 continuous days, we
Okay.
taper depending upon the severity. If anyone is not reached the usual period of 6, we will repeat the sessions.
Okay, so that means nobody should be doing occlusion. If you're going to do 10 days of this and children are okay and you have comparable results, why would you even do? So I'm saying we're missing something. That's why I'm asking you. Educate me, because if orthoptic is that good, why is anyone doing occlusion at all then? Because you're saying 10 days equivalent is equal to a whole year of occlusion. Is that the final conclusion?
Yes. But
Okay.
the patient has to come to the hospital for 10 almost continuous days within a span of 10 to 14
No,
days.
that is okay. That is
That
okay.
is really okay, isn't it?
That
If
is
you
okay. Coming for follow-up is not difficult at all. Only problem is continuous 6 months to 1 year of occlusion versus just 10 days of orthoptic. If that is equivalent, then why have occlusion at all in the
Yeah.
treatment armamentarium? Why
Course.
shouldn't we stop occlusion therapy at
That's
all?
yeah, let's stop occlusion. Let's
Yeah,
just,
stop
we go by
occlusion.
your study, we'll stop occlusion. You know, every child will come during summer holidays and the Dasara holidays for 10 days to your clinic.
The cost is slightly more for the orthoptic, around 500 rupees per section. Slightly.
Let's, you're not talking about, for example, Lux Turner. You're not talking about, $500,000. You're talking about 500 rupees. All I'm asking is there is something we are missing, because clearly the whole world has not shifted to orthoptic, right? So why are we still doing occlusion? What is a missing link is what I'm asking you. I don't know, so I'm asking you. It's okay. We don't want
It's
to,
okay.
make you. No problem.
Thank you.
Thank you. Thank you.